Good afternoon, everybody. Thank you very much for joining us today for this LIDC webinar, which is one of several that we've had over the course of the pandemic, dealing with problems, challenges, and hopefully solutions to issues in the global development landscape. If you are new to the London International Development Centre, do please take a moment to check out our website, lidc.ac.uk, find out more about the work that we are doing with our 5,300 membership community of researchers, students, academics, and NGO workers to make in the global development landscape. Could I please at this point ask that you all have your microphones muted? I'm afraid at this end we're getting people's breathing and coughing and so on, and it's likely to be a distraction to our speakers. So it would be very helpful if you could keep your cameras and microphones off while our speakers are presenting. Thank you very much for that. We may need to remind you of that during the course of the discussion. You all know why you signed up for this event. The issue of mental health is gaining increasing significance the longer this pandemic goes on, and particularly is of concern for those who've suffered with mental health issues before the pandemic was declared. So we're very privileged and grateful today to be joined by Giovanni Sala, who joins us from the World Health Organization in Geneva. And we have three members from the NIH Mental Health Policy Research Unit, which is based in London here and is a joint venture by King's College and University College London. We will be hearing from Senior Research Fellow, Dr. Luke Sheridan-Rains, and then we have the honour of being addressed by the director of that unit, Professor Sonia Johnson, and another colleague, Dr. Nick Harper, will join us later to discuss specifically work that's been done with the Lived Experience Working Group. So the format of today is exactly that. We will hear from our speakers, and then there will be time for questions and answers. We know that Zoom has changed the settings recently, so do familiarize yourself with where the raised hand function is. I have colleagues on hand who will try and take down names in the order that we see them. If you prefer, you can write your question in the chat for us to read it out. But until we've finished hearing from our speakers, we value your presence and we thank you very much for continuing to keep your microphones and cameras off while the presentations are in progress. So the only thing left for me to do is to invite you to live tweet. We did send out messages yesterday with the relevant Twitter handles. We're using the hashtag LIDC seminars, and of course we tweet at LIDC UK. So do feel free to connect with us on our social media channels. With no further ado, it gives me great pleasure to hand over to the World Health Organization speaker, Giovanni Sala. Thank you for joining us, Giovanni. The floor is yours.
Hello, everyone. Thank you very much for having me. I'm going to quickly share my screen and also stop my video while I'm sharing. So let me just do that very quickly. Please let me know if you can see my screen.
Perfect. It's perfect, Giovanni.
Thank you very much. Thank you. So today I'll be talking about COVID-19 and mental health from a global perspective. In particular, we'll be looking at the impact of COVID-19 on mental health, the current response, and a little bit of a few recommendations for future work. So first of all, a quick look at some epi data from around the world. If you look at the graph on the right, we have prevalence estimates of psychological distress from China, Iran, and the USA. As you can see, these estimates are quite high, 35%, 60%, and 45% respectively. Here it's important to keep in mind that the global estimates of prevalence of mental health conditions in non-emergency settings is of about 10%. So when there are no emergencies, the estimates of prevalence are 10%, and we can see that in these 3 countries, this has gone up quite a lot as a result of COVID-19. Data from Ethiopia backs this up, showing a 3-fold increase in the prevalence of depressive symptoms as a result of the pandemic. And from Canada, we know that 20% of the population aged between 15 and 49 years old had actually increased their alcohol consumption during the first wave of the pandemic. With regards to the neurological impact of COVID-19, we do not have conclusive data yet, but there's a bunch of my colleagues researching this at the moment. And unfortunately, the information we have for now is quite worrying. So we do not have enough information for any publications, or enough information, for publications at the moment. But unfortunately, what we have is quite worrying at the moment. What's very important to stress is that the impact of COVID-19 on mental health is not only measurable in terms of its impact on mental health conditions in the population, but also on mental health services. There are a few factors that influence this, as we can see listed here. Number 1, the risk of infection in hospitals and clinics is actually causing people not to fear going to look for services in these facilities, of course. And this applies to mental health services too. There are barriers to meeting people face-to-face, of course, at the moment. Mental health staff are being infected with the virus and, of course, have to take time off work. But maybe most importantly, one of the main factors is the conversion of mental health facilities into COVID-19 facilities to better respond to the crisis. So last year, the WHO carried out a rapid assessment in 130 countries around the world, looking in more depth at the impact that COVID-19 has had on mental health services. What we have found is that around 93% of countries reported disruptions in one or more of their mental, neurological, and substance use services. Then nearly 3/4 of countries reported at least a partial disruption to school and workplace mental health services. That 60% of all countries reported disruptions in psychotherapy and counseling services. And then more than 50% of countries reported disruptions in overdose prevention and management programs and critical harm reduction services. So emergency services have also been affected. Let's now look at what is happening in countries at the moment. So these are also results from the rapid assessment that was carried out last year. And we found that 89% of responding countries had mental health and psychosocial support as part of their national COVID-19 response plans. And that 2/3 of countries had created or had a functional mental health and psychosocial support coordination mechanism to respond to the COVID-19 pandemic. Unfortunately, despite this, only 17% of countries had specific funding for mental health and psychosocial support activities within the COVID-19 response. And now let's have a look at a bit more of on field activities. So last year, the WHO partnered up with the Mental Health Innovation Network and launched a call for stories for practitioners on the field to share their stories of how they are adapting to the COVID-19 pandemic and how they're making sure to continue mental health services during the pandemic. What we were mainly interested in at this point was, number 1, the challenges that people had been facing in continuing mental health services during the pandemic. Number 2, the innovations and the new technologies or the new strategies that they had developed to overcome these challenges. And finally, if they had any recommendations for other practitioners. And the objective here was to collect as much information as possible from the field to then share with the rest of the mental health community around the world. And the Mental Health Innovation Network was a great platform to do this through. If you are not part of this platform, I would highly recommend going on their website and having a look. So overall, we received over 100 submissions from 40 different countries. As you can see from the graph, most submissions came from Asia. We also had quite a few from South America. Some submissions from Africa, Europe, and North America, whether quite a few less from the Middle East, Oceania, and Central America and the Caribbean. But you can see that the variety of the geographical variety of the submissions was quite impressive. So before I go into these recommendations that were developed through analyzing all these entries, just a quick word about the other outputs that were created, the products that we managed to create through this call for stories. We had a series of blog entries that were published on the MHIN website. We had a series of video interviews with the practitioners that had contributed to the call for stories and that had the chance to further explain their strategies for continuation of care. We also partnered up with United for Global Mental Health to carry out a webinar in which we invited 4 of these practitioners to speak about their experiences. And finally, as I said, we carried out an analysis of the different entries in order to create a summary and a list of recommendations that would bring together the common elements of the lessons learned by the different practitioners. And the 2 main means of dissemination used for this were, number 1, a field report that was published on Intervention Journal, and number 2, a policy brief that was published on the MHIN website. And what I'm about to present is a list of 5 recommendations that were listed in the policy brief that you can find on the MHIN website. So keep in mind, these are recommendations that look at disseminating strategies for maintaining mental health services running during the COVID-19 pandemic broadly. So the first one is with regards to the importance of responding to people's basic needs as part of any mental health and psychosocial support intervention. What has become clear from years of intervening in emergencies is that people's basic needs like food, medication, and security, for example, need to be addressed before we begin thinking about mental health and psychosocial support. Now, this can be quite obvious to some, but unfortunately, it is not always the case on the field. And this was reflected in the entries that we received. And we were very glad to see this because this is also one of the principles of the global MHPSS guidelines published by the Interagency Standing Committee years ago, which at the bottom of their intervention pyramid have a response to basic needs as their main type of intervention. So a multi-sectoral approach is absolutely necessary in order to respond to all these needs. And we will see also in later slides that a lot of organizations actually created multi-stakeholder partnerships in order to respond to these different needs. Another point that I wanted to make is that as mental health practitioners, we have the responsibility to ensure that our patients or our beneficiaries have access to services that respond to their basic needs. But we also have a responsibility to advocate for the integration of the response to basic needs in more general strategic plans and strategies. The second priority, or the second recommendation, looks at making sure that people with severe mental health conditions and vulnerable groups are prioritized in our response. As we said, during the pandemic, there was a general lack of resources for mental health services and a disruption in these services. Now, when this happens, of course, we don't have enough resources to reach all people in need, and a prioritization exercise has to happen. Keep in mind that most people are not actually going to need specialized care, and they will be okay with community-based and non-specialized care. The people that we want to focus on with our specialized care are the most vulnerable. And there's a great story we received from Uganda, from an organization called Thrive Gulu, that had been working with gender-based violence victims since before the pandemic. But during the pandemic, noticed an increase in incidents of gender-based violence in the community. So what they did is they focused most of their resources on outreach, on community outreach for identifying people who had been victim of gender-based violence and to provide services to them. They did this mainly through community radio stations and community outreach workers. The third recommendation looks at protecting and promoting staff and caregiver mental health. And this is something that came up in a lot of stories. And the idea is COVID-19 responders and all types of mental health staff are among the people who are being most affected by the pandemic at the moment. And they're also extremely crucial for responding to the COVID-19 pandemic, of course, and for providing mental health and psychosocial support services to us and to each other. What is important is to make sure that principles of mental health and psychosocial support are actually integrated in all aspects of the work that is done by COVID-19 responders and MHPSS, mental health and psychosocial support staff. And there's a great story from Sarawak in Malaysia, excuse me, where in Miri General Hospital, they set up a series of strategies to support the mental health and well-being of their workers. First of all, they set up a mental health and psychosocial support team within the hospital, which had been trained in psychological first aid, which was responsible for helping workers out that were experiencing severe levels of stress within the hospital. Secondly, they created a staff room in which any member of staff could go at any moment to relax, have a nap, play some games, chat with colleagues in order to reduce stress levels. And finally, they created what I think is a very interesting program for management, for hospital management. They created a buddy system by which they buddied up all managers in order for them to be supported by others during the most difficult times of the pandemic. The fourth recommendation focuses on messaging and communication channels and collaborating with caregivers to engage hard-to-reach populations. Now, we all know that technology has been the medium of choice for communication throughout the pandemic, but we have to consider that this is not accessible to everyone, especially children and the elderly, for example. We also have to consider that not everyone can read. There's a lot of people in some countries that cannot read, and so the use of videos can be instrumental here. And that in certain countries, there are a lot of different languages spoken. So when we develop information material, it's important that we develop it and translate it in different languages. There are some great stories that exemplify collaboration with caregivers for hard-to-reach populations. And I'm going to talk to you about Cape Mental Health in South Africa, who work with children with intellectual disabilities. Now, what happened during the pandemic, of course, is that children could not come to their facility anymore and were stuck at home with their parents. So what they did is they linked up with the parents of these children and trained them to provide intellectual stimulation activities and psychosocial support to their children. And they supported them by sending them videos regularly to show them what type of exercises they could do with their children at home. The final recommendation is with regards to the importance of having central decision-making mechanisms as well as coordination mechanisms, and creating cross-sectoral partnerships for more efficient responses. Now, for those of you who have worked in emergencies, I think we all know that the lack of coordination in emergency response can often be a problem. And this creates a lot of issues, including, for example, the overlap of services, dysfunctional referral mechanisms, as well as sometimes certain needs of the population not being met. And cross-sectoral partnerships become very, very important in these instances in order to be able to provide holistic services. And a good example of this came from Nairobi in Kenya, where various organizations of different kinds, completely different organizations, actually came together to provide holistic services to the community. So there were 3 different organizations involved. The first was a faith-based organization that decided to include prevention messages for COVID-19 in their daily sermons. The second organization was a community-based organization that organized a fundraising in order to raise funds to buy food and clothes for the most vulnerable and poor people in the community. Finally, there was a mental health organization that set up a helpline that people could call into when they were experiencing high levels of stress. And now a final word about 3 priority actions that we would like to see going forward and that we advocate for going forward. These were recommendations that were developed through the rapid assessment that was carried out last year by WHO. And the first one is about allocating resources to further implement mental health and psychosocial support services within the COVID-19 response and recovery plans in countries. The second one is about maintaining essential mental, neurological, and substance use services in line with WHO recommendations. And the third is to strengthen the monitoring systems to actually monitor the changes in service availability, delivery, and utilization at the country level in order for us to be able to better respond to these changes. And this follows another important finding from the desk review, which is that simply there is not enough data that is being collected at country level with regards to the impact of COVID-19 on mental health. So that is it from my side. I hope I have kept to the allocated time. I thank you very much for this opportunity, and I will be happy to take some questions later on. Thank you.
Thank you very much, Giovanni. Now that I have the screen back, that was an excellent, very comprehensive introduction. We're already getting questions about it in the chat, so we're looking forward to a fruitful discussion. I will probably pick up on some of the things that you said in that introduction during the Q&A later, but we'll move straight on now to Dr. Luke Sheridan Rains, who is from the Mental Health Policy Unit, which is under the auspices of the NIHR, a joint venture run by King's College and University College London, which is obviously here in London. He's a senior research fellow with that unit. So over to you, Dr. Sheridan Rains.
Thank you. Let me just. Okay, so as Sheen's mentioned, I'm a senior research fellow with the NIHR Mental Health Policy Research Unit. And over the last year, we've been conducting a program of work to look at the impact of the pandemic on the mental health services and on service users. So I'm going to begin with a bit of background to that program of work and discuss the kind of main themes really in our results from the impact on service users. Then Sonia, the director of the PRU, will discuss the impact on the mental health services. And then finally, our colleague Nick will hopefully be able to join us to discuss the experiences of the pandemic from a sort of service user perspective. So by way of background, we conducted a program of work which is still ongoing. And today we're going to be talking about the bits that have so far been published, either in peer-reviewed journals or as a preprint, so not yet peer-reviewed. The first of these, well, the first two of these, we conducted quite early on in the pandemic, last sort of April, May. And the first was a synthesis of international publications. So we identified about 800-900 articles, and we synthesized these. And these were early reports of the impact of the pandemic on both mental health services and people with mental illnesses. And it was an international synthesis. So we collected articles from 28 countries, which were in these 6 languages: English, French, German, Italian, Spanish, and Mandarin Chinese. At the same time, we also conducted a survey of 2,000 clinicians working in the mental health services here in the UK. And two pieces of work which are currently out as preprints are one is a qualitative study where we interviewed 49 service users to explore the kind of views and experiences of the pandemic. And the other one was a umbrella review of 19 systematic reviews about telehealth interventions. So I think the key themes that we picked up on in relation to the impact of the pandemic on mental health service users was that there was a clear deterioration in the mental health of many people. This was particularly true of people with pre-existing conditions such as depression, anxiety, OCD, and eating disorders. And the main drivers of this deterioration included things like health anxieties, loneliness and isolation from the lockdown, withdrawal and reduction in services, and societal and economic worries or concerns. Part of this was that the pandemic disrupted the routines and activities of many people. So, for example, in the case of people with eating disorders, it may well be that they had a certain routine or certain coping, certain ways really of coping with their condition and of making sure that they maintained good eating, a good diet, which the disruption of the lockdown made that much harder for people. It was the disruption to their routine that made it much harder for them to cope. We also saw increase in loneliness and isolation, increase in domestic violence and family conflict. And many of these things were exacerbated from overcrowded housing, financial worries, and difficulty in accessing essential services such as supermarkets. And this was especially true if people didn't have access to the internet. In terms of people's experiences of the mental health services, many service users felt that the pandemic had exacerbated already existing inequalities or social adversities that people faced. For example, people who already had poor access to services or lived in areas where perhaps services were not that well funded anyway, saw a pretty steep decline in the quality of the services or in the quality of the care that they received from those services. This was to do with services needing to take a bit of time to adopt telehealth measures or social distancing measures, but also it was in some cases that people found it much harder to actually physically access, or people would have poorer internet access, for example, so it just made it much harder for them to access care. We also found reports that minority groups were particularly adversely affected by this change in provision of services. There was a widespread implementation of telehealth, but this came with challenges for people, particularly those people who were in crowded homes, such as a lack of privacy. Many people spoke about how they perhaps weren't quite as open with their families about their mental health as they were with their clinicians, and so it was difficult for them to find suitable places at home to engage in therapy or support. With other difficulties included poor internet connections, and for some people, telehealth, so support by phone, video call, or in some cases WhatsApp, significantly reduced the kind of therapeutic relationship that they had with their clinicians. As a rule, video calls were considered to be generally quite good by a majority of people, although some people found it difficult, but receiving support solely by WhatsApp, which is what happened in some cases, or by telephone, really negatively impacted on therapeutic relationships. For some service users, the mental health services seem slow to adapt or offer support, especially where service provision was already limited, and this led to a particular deterioration in care in those areas. So, for example, in some cases, staffing was significantly reduced, plus staff had to learn to adopt these new ways of supporting people, and those challenges just led to significant deterioration in care for many service users. The overall increase in worries and anxieties and deterioration in mental health, combined with poorer support from the services, meant that there was a greater pressure on family and carers to support acutely ill family members or friends. At the same time, normal support that carers may have was not always there. Ward environment service users reported were particularly bad and stressful. This was due to social distancing being introduced into wards that meant that people were spending a lot more time isolated in their rooms, spending much less time in shared environments and interacting with other people far less. They also saw their families and friends much less, so they had much less of a support network, and they were, leave was cancelled. So in addition to that greater isolation and kind of boredom associated with that, there was also, of course, the anxieties associated with potentially very fast spread of infection around the ward environments. However, we did also find reports of positive impacts from the pandemic as well. Some people felt better connected and better understood by other people. This was particularly true in cases where people perhaps experienced something like social anxiety or health anxieties. And it meant that in some cases, people felt like the general public perhaps understood what life was like for them a bit better, or their family and friends perhaps understood what life was like for them a bit better. And in some cases, people were actually quite liked having fewer people out and about. It made them feel less stressed or safer. And some people also spoke about the experience of the pandemic, making them aware of their own ability to kind of cope with these situations. So some people, in particular, people who felt that they were coping particularly well, found that it actually gave them more confidence about their ability or their resilience. Some service users also reported benefiting from new self-management strategies that have been suggested or implemented, and this was particularly the case with online peer support. So some people who perhaps found it difficult to physically attend peer support or to receive peer support face-to-face, perhaps again people with social anxieties or who are isolated, actually found the rise in peer support online really beneficial and something that was a major improvement due to lockdown. Finally, for some people, again, people were perhaps already quite isolated or had social anxieties. The innovation in remote and digital forms of care was a significant improvement to them. This was also true for people who perhaps found it difficult to schedule therapeutic appointments in amongst their day. So perhaps people that were at work, it made it much easier to fit these all in. So many service users actually hope that the kind of positive aspects of telehealth could be carried forward post-pandemic. So at this point, I'm going to hand over to Sonia to talk about the mental health services.
Okay, hi, thanks very much for inviting me. I'm going to share my screen with you. Okay, so I'm going to just summarize to you briefly some of our findings. In fact, Luke's covered a bit of it already, but some of our findings from the point of view of what's happened in mental health services. We're drawing on this framework synthesis, this large-scale analysis of articles from around the world early in the pandemic, also from a UK survey of staff experiences, from some of the other papers that have come out during the pandemic, and also from work on telemental health that we're now carrying on with for the UK Department of Health and Social Care. This is more than anything from the perspective of this country, as that's where our primary research has been carried out, and also from other higher to middle income countries, which are the main places that have produced literature. So apologies that what I'm going to say is not truly global in its scope. So just to give you an overview of what we've found, particularly early on, has happened to services during the pandemic. So hospital services, the international trend seemed to be for an early reduction in admission rates, followed by a rebound as the world opened up a bit over the summer, but with compulsory admissions remaining more stable than voluntary throughout. The big challenges that staff and service users report in hospitals are, as Luke's already said, infection control, people being bored, and actually people can be very isolated following admission, particularly where they're asked to quarantine for a period in hospital rooms. Usual visits to the community or visits from family and friends aren't allowed, and the usual therapeutic activities are often not happening in hospitals. So while there are obviously many people around, if you're admitted to a psychiatric hospital, actually it's surprisingly lonely and isolated experience currently, and one that we're told can be very boring. There's another report from around the world is that in some countries there's been a pressure for people with mental health problems, with particularly severe mental health problems and COVID-19 infections, to be treated in psychiatric hospitals. And where that's occurred, it's raised concerns about them not getting good enough physical health care. Some of the adaptations and innovations that have happened in hospital in various places include COVID-19 specific mental health units with enhanced physical health input, enhanced use of technology within the hospital to try and reduce isolation and maintain therapy. So, for instance, hospital patients being given iPads to allow them to keep in touch during the stay, and home treatment initiatives to try and prevent admission as much as possible. This is a slide of the infection control challenges in mental health care settings as they were reported by UK mental health staff. And apart from the sort of universal PPE availability challenges, there are some ones that are quite specific to mental health. So a feeling that there's a conflict between what it is to provide good or safe mental health care with personal contacts and infection control, and some particular ethical and practical issues around situations like restraint in hospital. There are issues where service users can't or don't manage to follow infection control guidance, often because of their state of mind. And whether in the community or in hospital, many premises where mental health care is provided don't allow for good social distancing to take place. So looking at crisis and emergency services, again, the reports seem to be of an initial drop in referrals to crisis care and in A&E attendances, subsequently returning to usual and possibly higher levels. What happened to community crisis services has varied hugely around the world, with as reported in the papers that were published, with complete shutdown in a few places, but most continuing with some sort of mixture of face-to-face and telemental health. And there are a lot of reports of mental health hotlines being in high demand during the pandemic. And some of the challenges in crisis care have been of trying to carry out home visits safely, of trying to work in A&E alongside COVID pressures, and of following the law in implementing compulsory admissions. Doesn't seem at the moment that there's a rise in suicide attempts or in suicides reported around the world, although that's been much predicted. Some adaptations and innovations here too. So in the UK and in other countries, we've seen new forms of crisis service rapidly established, such as walk-in centres outside hospital to replace A&E. Community services, again, the demand seemed to reduce initially with a drop in referral and a drop in contacts, but then a subsequent rise, and that seems to have been seen especially for children and adolescents. And again, both within and across countries, very big variations in how much has been provided, both face-to-face and remotely. And the predominant adaptation has been telemental health, so video calls and to some extent phone calls and messages. And there are a lot of specific groups where particular challenges are being reported by people working in the community services. So telemental health has become a particular focus of interest in which we have ongoing research. Some of the pros are that it's helped keep things going somehow. People have had a service who wouldn't have had it otherwise. It's accessible. Some people find it more accessible. From a staff point of view, there are efficiencies, time is saved, and a reduced environmental impact is also noted. And something that people seem to have been particularly happy with during the pandemic is how much it facilitates staff in different teams or different settings meeting and communicating with each other. And there are new forms of online intervention. For instance, quite a lot of new online support groups which seem to meet some people's needs. On the other hand, concerns about telemental health, about exacerbation of inequalities, the potentially more challenging nature of assessment, it's harder often to establish therapeutic relationships, people say, especially where they don't already know each other. There are obvious technological and staff training barriers. There are great variations both among organisations and individuals in their willingness and confidence to get stuck in and find ways of doing this. People's privacy for receiving calls is a big concern, and its confidentiality. And some people find this form of appointment alienating and intrusive. There seems huge individual variation in how people find this. We've done, as Luke mentioned, an umbrella review, so a review of reviews looking at the pre-COVID evidence on telemental health to try and inform further work in this area. And basically the work suggests that telemental health can be safe and effective and acceptable, but it's striking that the evidence is almost all from relatively small scale implementations with people who've opted in. So finally, what do people hope and fear when we've asked staff or in service user articles about the pandemic? Well, there are some, when we asked UK mental health staff, was there anything they wanted to keep? Most people said yes, and that tended to relate to telemental health for selective purposes, but also just to some extent retaining some of the flexibility and ability to cut through red tape and innovate quickly that people have experienced during the pandemic. But there are many fears as well. One is that demand will gradually rise, or will potentially rise quite quickly in the aftermath of the pandemic due to factors like trauma, loss, economic impacts, the effect on mental health care staff of burnout and of the traumas they've experienced. There are fears that ways of working or reduced levels of service that have been adopted to cope with the pandemic may be inappropriately continued, that existing inequalities, particularly ethnic inequalities, have been exacerbated, and also that perhaps in the pandemic recovery, people already living with significant mental health conditions may not be the main focus. Okay, that's my presentation. I don't know whether Nick, who we hoped would add a comment from our lived experience researcher group, has managed to join.
Yes, I'm in. Yes, I'm in, Sonia.
Nick, good to hear you. Go.
It was a bit of a technical nightmare.
I'm ever so sorry. There seem to be gremlins with your sound. It's unclear.
Okay.
Right.
I'll do the best I can. What
Nick, I'm afraid we really can't hear you. I don't know if it's possible for you to join us from another device. This has happened.
I'm afraid not.
Where right. It seems to like the first part of your sentence, but if you speak for longer than 3 words, it's then a bit garbled. I'm not exactly sure how we can get around that. Let's give it another go, and if not, I'll go into summing up what we've heard from the speakers so far. And thank you very much for joining us, by the way.
Okay. I mean, yes, well, basically, I've been lonely and is this working?
That's slightly better at the end there. Continue for now, and we'll see how we go.
Okay. And with the onset of COVID, obviously, the project.
Very sorry, it's gone again. It seems to have. If
okay, look, let's just forget it.
Yeah. Thank you for joining us. I think we'll be in touch with you separately, and we'll be able to post your presentation on our website, so at least people won't miss out completely.
And I just wondered whether Nick, if there are any sort of key comments you've got, whether you might post them in the chat, maybe.
I'll put them in the chat, Sonia.
Yeah.
That's wonderful. Thank you very much, Nick. Apologies. Occasionally the tech fails, which is one of the things, is a good illustration of some of the obstacles that mental health users are facing in, as Sonia and Luke referred to. When the tech doesn't work, it does result in increased isolation and frustration. And I think that's the case for all of us.
Exactly.
Thank you so much to everyone for your wonderful presentations. So much information there. I'm going to start by reverting back to Giovanni's presentation. I also want to echo what he said about the work of the MHIN. Do check out their work. As Giovanni said, there will be blogs and video interviews there, a lot of which are very inspiring. Giovanni, it was really interesting to hear about the widespread of geographical response. I certainly was particularly inspired to hear about the work that's being done in South Africa to train parents and caregivers in how to provide care for their children with mental health needs, and the work that you spoke about in Sarawak in Malaysia and Uganda. We are recording this webinar. It will be posted on our website and our YouTube channel. So if any of you have missed some of Giovanni's introduction, you will be able to watch it it again. We're also particularly glad, given that we are, LIDC is an interdisciplinary, collegiate, and we have a number of NGO members, institution. We're very keen on the idea of cross-sectoral partnerships, and it was great for us to hear you talk about such partnerships. Before I move on to referring a little to Luke and Sonia's excellent presentations, I do want to thank you all for having kept your language so accessible. I am not a mental health researcher. I have no experience in mental health research, so I'm particularly grateful that I was able to understand everything that you said, and I'm sure the rest goes for our audience. We often have a wide spread of people joining us for these seminars. Sorry, excuse me. So if any of you would like to pick up on the points that Sonia and Luke made, they also made the generic point about something that we've all noticed during COVID-19, which is that it's exacerbated existing inequalities and the challenges that we face in surmounting those. So if any of you have any questions, do please feel free to indicate in the chat. There has been quite a lively conversation going on in there. I'm going to change my view so that I can see if any of you have your hands raised. Do feel free to use the raise hand icon if you would like to come back and share with any of our speakers, if you would like any clarification or to make any comments. Do use the raise hand function and we'll take you in the order that I see you. So first of all, I hope I'm pronouncing your name correctly, Yorum Shambe. If you would like to unmute and even use your camera if that's available to you, do come back and share with us. Thank you.
All right, thank you. Hello.
Hello.
Yeah, so I'm interested particularly in the issues concerning remote learning that has been forced upon us by the COVID situation. I don't know if there are any studies about mental health issues among students that study remotely across educational levels. Thank you.
Thank you very much for that. I'm actually going to take a question that's in the chat from Timor-Leste, Joaquin, an MSc student from LSE, who says he has 2 questions for Giovanni. So Joaquin, would you like to unmute yourself and ask your question? And otherwise we'll open Yornun's question to our speakers. Could I remind those of you who aren't addressing the panel to please keep your microphones off. So over to you, Joaquin.
Yeah, thank you so much. Good evening from Timor-Leste. So my first question is, how can we tackle mental health issue in the context where a society experience brutal and violence colonialization history, and also in the context where people who suffer from mental health issue, they're being stigmatized. So that's the first question. And also the second question is about prioritizing the vulnerable people in terms of mental health issue. How would you prioritize vulnerable people in a context where there is no organization that collect robust data to inform the decision making in terms of prioritizing vulnerable people?
Right.
Thank you so much.
Okay, so I won't take any more questions for now because those 2 speakers have raised a number of various issues that I'm going to ask our panel to address. Referring back first of all to Mr. Shambe's question about online learning. Is there anyone who would like to address that? Please feel free to unmute yourself if you're on our panel, if you can respond to that.
Not from a very specialized point of view, but I understand there are quite a few studies ongoing of showing a significant COVID impact on students' mental health, not surprisingly. I'm not sure whether it's greater than the impact on young people generally. Certainly young people have tended to take the brunt of COVID's impact on mental health, I've not come across anything specific to online learning, and I'm not absolutely sure how you could look very specifically at that, but perhaps others have come across more evidence than I have.
Right, thank you. I think I'm actually going to move on to the second question there, because that was a question, if you like, in three parts. The first part of which, if I recall correctly, was referring to how provision can be made in a society that's suffering the effects of trauma. And the speaker then also touched on stigma, mental health stigma, which in my experience, I'm glad to say, seems to be something that we are effectively moving to combat, and how we prioritize working with people who need the care most, so the most vulnerable. Would any of our panel be able to address those issues, please?
Hi, Shireen. I'd be happy to have a
Brilliant. I was hoping you would, Giovanni. Thank you so much. Please go ahead.
Okay, so starting from the point about stigma and misconceptions, this unfortunately is the case really all over the world, in different ways and to different extents in different countries. But this is certainly a problem that most mental health practitioners will have to face. I believe that in populations where mental health is extremely misunderstood, awareness raising is what we need to do. We need to make sure that on top of creating services, so creating supply of services, we also create demand of services. And I think this analogy goes well with what we're doing. So unfortunately, there is not a lot of data with regards to what type of awareness raising work is actually effective in low and middle income countries. So I would not be able to tell you from a scientific point of view exactly what kind of activities we should be looking at. But what is for sure is that we need to create that awareness, and we need to clarify things with respect of local perceptions, though, and local and trying not to go against what are the local perceptions, but rather to work with them and to work around them in order not to create too much of a contrast. Because when we create too much of a contrast, the danger is that our messages will just simply not be accepted by the community. So that's the first thing. With regards to populations victim of violence, and not just any type of violence, colonial violence, I think that's a very interesting question. And this is to be considered, I think, as a community-wide issue. And as such, it has to be addressed. So involving community leaders, but the community as a whole in the response to this issue, I think is absolutely crucial, because they will have shared experiences of what has happened to them. We've seen there are a lot of countries, for example, Rwanda, where sociotherapy is working very well to deal with the violence of the genocide. So I think starting from a community-based approach, involving as many people from the community as possible, and focusing on interventions that have been proven effective for violence-affected populations. Just as an example, the WHO has developed a humanitarian version of the MHGAP intervention guidelines package, which is basically a training package for non-specialized workers to be able to provide mental health and psychosocial support. And there is a humanitarian version of that, which is in partly focused on violence-affected populations. With regards to the question on how to prioritize people with severe mental problems when we don't have data, that is also a really good question. And I think I will start by saying that unfortunately, in my experience, when a new emergency arises in many countries, we usually do not have a lot of data on mental health issues in that country. So what we usually do is, first of all, we use data from other similar contexts, as similar as we can get, and we do with that until we have data from our context of intervention. And secondly, we try to look at routine data collection. So data doesn't have to be collected through very systematic and very rigorous scientific methods from the outset. If we don't have the resources or the capacity for that, we can focus on routine data collection in routine services. So it is definitely a big challenge, the absence of data, but in these situations, we try to do what we can with what we have.
Thank you very much. Before I revert back to comments and questions from the chat, I'd like to make a couple of points here, which is, first of all, is I'm really pleased that that question was asked by our friend from Timor-Leste. I am myself from Sierra Leone and I'm half Lebanese. So these are both areas that have been through a lot of trauma. I was in Sierra Leone when the war was breaking out. And people in Sierra Leone are still, many years later, dealing with the after effects of the trauma, and then of course the Ebola epidemic, and now COVID-19. So although COVID-19 has thrown into sharp relief some of the pre-existing problems, there are a lot of these issues that were still needing to be dealt with way before the pandemic ever kicked in. We're still hearing reports from Central African Republic, from Syria, from Yemen, from Ethiopia, of conflict and violence, and all of this is going on in the context of a pandemic. So thank you very much for your work on that and for your answer to the question. I think it was very comprehensive. I'd like, if I may, to pick up on Nick's comment that he's very helpfully placed in the chat. So those of you that are here with us today will be able to read it for yourselves, but for the purposes of the tape, as they used to say in court, I will read it out. He says the main lessons that he learned, and this is clearly referring to his work on lived experience with the NIHR Mental Health Policy Research Unit. The main lessons that he learned were of quote unquote significant minorities. This is the significant minority who found tech impossible or inaccessible, or who felt sidelined by the rush to remote therapy. This significant minority found lockdown actually a positive experience. And we've just heard from Sonia about why this was so. He also mentions concerns about services being overwhelmed by new users once restrictions are lifted. So if anyone would like to comment on that, or ask a question, again, please do go ahead and use you're very shy about raising your hands, I see, but do feel free to go ahead and do that. I've noticed a couple of comments that I'd like to come to again, also in the chat. One is from Kelly Dixon and one is from Gordon Johnson. It would be great, Gordon and Kelly, so it's Gordon Johnston, not Johnson. Be great if either of you are willing to unmute yourselves and ask your questions so that those who will be watching a recording will get a benefit of the answer and be able to see you. So are you willing to go ahead and do that? If not, I will just read the question out.
Hi, yeah, happy to chip in. My question was really following on from the last comment there around the anticipated demand on services, which Sonia touched on. And we know that many people with existing mental health conditions have had conditions worsened by pandemic and by lockdown. We know there are a lot of people who are approaching services for the first time. And we also know that we're going to go into economic recession. And we know that that on its own is always correlated with increased demand for mental health services. So, and just how our service is going to cope with what is likely to be a massive increase in demand over the next year.
Would anybody like to come back on that? If not, I will move on to, yeah, actually, I'll leave a space for someone to come back on that, please.
Yeah, I can have a go. I mean, it's a very good point, and I don't think I can come up with a strategy. I guess as a researcher, one thing that I think is key is that we try and measure it as effectively as possible, the sort of changes in demand, because I think, as Luke suggested, and as some of the research suggests, the impacts aren't altogether predictable. So it seems that there are some groups of people who are managing relatively well, and others, like children with mental health problems, who are especially impacted. It seems that, at least so far, there are lots of predictions that the suicide rate was going to quickly go up, but that hasn't actually been the picture as yet. So I think one thing that's crucial is that we get a handle as quickly as we possibly can on where the demand actually is and for what. Ways of possibly addressing it would include using telemental health as kind of efficiently as and appropriately as we can, but with a looking out all the time for who gets excluded, who can't use it, thinking about the role of the voluntary sector and some of the organisations who've stepped up and innovated during the pandemic and have supported people in very helpful ways, the role of peer support. But ultimately, more resources are going to be needed, aren't they? That certainly needs to be part of it.
Right. Thank you very much. Yeah, I think that goes without saying that we are all going to have to be part of the push for the importance of mental health to be higher up the political agenda globally than it currently is. As Giovanni pointed out, with 93% of countries reporting service disruption and with depression rates rising, which aren't surprising at all, given the level of anxiety and lockdown isolations and restrictions and loss of income. And of course, the grief that comes from losing people. We have to remember that every time we go out, we're being told that we have to be careful not to go too near someone because they could give us a disease which could kill us. So people have died and other people are suffering from the disruption of their family lives and so on and so forth. So it is really to our benefit that we've been able to have you here today to tell us about things that can be done and have been done, particularly in the Global South. I'm just going to read out a comment from Kelly Dixon. She's unable to unmute herself right now, and she says that the Epicenter, EPPI Center at UCL, are currently searching for the evidence base on the impact of COVID-19 on CYPs, and I'm going to ask someone to explain what CYPs mean.
Children and young people.
Children and young people. Thank you very much.
Concerning group.
Mental health with a schools education focus, just at the start of the ESRC project at the moment. But yes, it's a key policy priority area, which is good to know. So we have approximately 5 minutes before our official end. So I'm going to start wrapping up. Before I do, I will remind you all of the fact that LIDC is a membership organization. We have a small staff team, which is very, very keen to do our bit to tackle whatever problems we can in the global development landscape. If you have a look at our website, our blogs, our featured member articles, the events that you have, you'll see the wide spread of events that we organize, and we invite you to be part of the LIDC family. If you are in one of our member higher education institutions or one of our NGO members like WaterAid or Oxfam, then membership is free. If you're not in a membership organization, you can now, as of this year, join LIDC as an individual member. So we do a number of things, both on and offline. Do connect with us. I am going to hand back now to our speakers to see if they have any final comments or final. thoughts before we close the seminar. Should we start again with you, Giovanni, if you don't mind? Hand over to you.
Thank you. Thank you very much, Shireen. I've found a very interesting question from Gregor from Mozambique in the chat box that I would really like to touch upon. So he's asking, talking about the aftermath, in your opinion, what can we do to make sure that the efforts we make today to strengthen mental health services will continue in the long term and not die out as soon as the pandemic is over? And I think this is a great question, especially for a webinar organized by you, and something that I have focused a lot in my previous work in emergency settings. There is a great publication by the WHO called Building Back Better Mental Health Systems After Emergencies that I recommend everyone to look at. And it talks about this precisely. It looks at different case studies from different countries, and it comes up with a series of common recommendations or common points that brought these countries to success in building mental health systems more sustainably, I guess, thanks to the opportunities that had been created through emergencies. And I just want to touch upon 4 main points here. The first one, the first main kind of strategic point, is to begin planning for sustainable mental health system strengthening from the very outset of an emergency. If the emergency has already started and we haven't done that yet, that's okay. Let's start as soon as we can. The second point is to engage in system-wide change. So let's not focus only on service provision, for example, but let's also focus on supervision. Let's focus on training. Let's focus on the financing system within the public health system. Let's focus on monitoring and evaluation. Let's focus on pre-service training. Let's focus on all the different aspects of the health system in order to integrate mental health appropriately on a system-wide level. The third point is about engaging communities and local stakeholders from the outset. And the fourth is about integrating services into already existing systems and not creating parallel systems. And I think these two go together. So working with local stakeholders, local leaders, people from the public health system is absolutely necessary in order to have them engaged in the process from the very outset, and not just leave them the burden of having to strengthen the public health system once the emergency is over. So a great publication. I do recommend, again, having a look at it. And thank you very much, Gregor, for the question.
Thank you. Sonia and Luke, I'll hand over to you if you have any final words, quote unquote. Right. In that case, while you're thinking of your final thoughts, where did I get that from? The Jerry Springer show, I believe, back in the day, my misspent youth as an undergraduate. Anyway, less about that and more about equitable partnerships. As you may know, LIDC leads a large action against stunting hub. We actually have their communications worker with us today, Alessia Gasco, and they recently had a really fascinating discussion on equitable partnerships. We generally record our webinar, so I'm sure that will be available to see on their website soon. But on the topics of equity, equality and decolonization, I just want to make a plug here for the fact that LIDC is convening a working group on decolonization with our member colleges. So UCL, IOE, SOAS, Birkbeck Geography Department, Brunel Department of Politics. Many of our member colleges are part of this decolonization working group, and we are working towards a conference next June. We've already decided that it will be online over 2 days, 23rd and 24th, and we aim to have as many speakers as we can from the global south, because there clearly is disparities in access to everything, from facilities to publishing rights, so on and so forth. So again, keep in touch with LIDC if you want to know more about that. I'm going to thank everybody who's here today. Do still please keep in touch with us. Let us have your ideas, your thoughts. Join LIDC. And I'm very happy to see that Sonia has unmuted, so I can now successfully hand back to her.
Yeah, I don't want to keep people because we've basically run out of time, but I guess there are a lot of fears for the future, and we need to mobilize quickly and collect as much information and as many ideas about how to deal with the situation and useful innovations as we possibly can. But I would also support the idea of building back better, that there are things about addressing inequalities, about co-producing with other stakeholders, particularly with people with relevant lived experience, about harnessing technology, that actually have been opportunities for a long time that we've not really taken as much as we could. And I guess it's a quite hard point in history at which to be optimistic, but I think there are some opportunities, as Giovanni's suggested, really in all settings at this point. Thank you.
Thank you. Final point, I can see Vincenza Colonia has commented not to forget LSHTM. London School of Hygiene and Tropical Medicine, one of our member institutions. Definitely going to give them and their work a plug, because a colleague from LSHTM, Grace Ryan, who works with Giovanni on the MHIN project, Mental Health Innovations Network, I think, actually connected us with Giovanni, who came and spoke today. So yes, a definite plug for LSHTM. And we are happy to plug you all. So please keep in touch with us and let us know about your publications, events that you would like us to plug, research that you want us to report on, membership activities that you want us to organize. We do a whole number of things. So keep in touch, stay safe, be positive, but remain negative. Look after yourselves, and thank you very much for joining us today. Goodbye.